Well, welcome back. I'm going to be talking this afternoon about lumbar punctures for ruling out subarachnoid hemorrhages. And in the last 15 years, there's been a lot of data that can inform our care on this topic. And so this lecture is going to go through some of the recent literature on that topic. And the question really has become, to tap or not to tap? That is the question. And so what's the state of the literature right now with regards to clinical decision rules? And as I said on the panel earlier today, anytime somebody says rules, I get all excited and it gets the hair on the back of my neck up, because I prefer tools, clinical decision tools, or a clinical decision instrument. And the person who's come up with a lot of these is Dr. Ian Steele out of Ottawa and his group with Jeff Perry and Team Vank. They've got all these Canadian rules, like the Canadian CT head rules, Canadian C-spine rules, but it started off with the Ottawa ankle rules, the Ottawa knee rules, and it's the Ottawa ankle rules is the most validated clinical decision instrument in medicine. And so, because I have an issue with this, calling them rules, I confronted Dr. Ian Steele at our national meeting at a social function to let him know what I thought about his rule stuff. And he's a great guy. He's sitting there, he's very formally dressed, he's got the suit and tie, he's got a nice Chardonnay, and I come up to him in shorts and a t-shirt and stuff or something like that, and I'm holding a beer. And so we got a picture of the two of us together, and we've got a nice meme now. It says, which is the rule and which is the tool in this picture. So he's done a lot of great work in this area. So we're going to go back 11 years to 2011, and this is when some of these clinical decision instruments were built upon, and when we got this idea that, hey, you don't need to tap everybody. And this was Jeff Perry's work, and it looked at a cohort of patients. It was 3,100 plus patients. And these were consecutive patients that came into these academic centers in Canada. And what they looked at was how good is a non-contrast CT head for ruling out a subarachnoid hemorrhage. And key to this is that you had to have an advanced scanner. So they called them third generation scanners at that point in time. Now we have like these slices, they can do like 1,000 slices. They can see one red blood cell, it seems, outside of the vessel. But it had to be an advanced third generation scanner, and it had to be read appropriately. And so what they looked at was over 10 years at these 11 centers in adult patients with acute atraumatic headaches undergoing a CT who were GCS 15. So that's how you got into this study. The overall sensitivity, which means true positives, for that was 93%. And you're going, well, why are we saying we can rule it out? Well, in the subgroup that were scanned within 6 hours, before maybe the blood could be reabsorbed, right? Within 6 hours, the sensitivity, 100%. 100% sensitivity, true positives. It picked up all of them. There was 4 patients missed. They were all over the 6-hour time frame. And so they concluded at that point that, if you've got an advanced scanner, you've got someone with under 6 hours, and you get a clean CT head, you can be done and say, we've ruled out a subarachnoid hemorrhage. And then abstract number 2 is from the same group in Ottawa, and they validated a clinical decision instrument, right, that looked at ruling out subarachnoid hemorrhages. And there were 6 components, and it'll be on an app. MD Calc has this. And the 6 components were neck pain or stiffness, you're going for a CT. Age greater than 40, and if you've suspected they have a subarachnoid hemorrhage, going for a CT. Witness loss of consciousness, CT. Onset with exertion, CT. Thunderclap, immediately peaking, CT. And the last one was limited neck flexion, which is a bit subjective, right? I don't know, how much can you move your neck? If you were no to all of those things, then you didn't even need a CT. Okay, so that was their clinical decision instrument. So they had 1,100 patients in that abstract that looked at that, and they found that in the prevalence, how many people actually had a subarachnoid hemorrhage was about 6%, and the sensitivity, the true positives for this clinical decision aid, was 100%. Now, it's always important to look at what's the confidence interval, what's the 95% confidence interval around that point estimate, right? If it's really tight, what number are you willing to miss? What's the lower end of that? And it was 95 to 100. So a potential of missing 1 in 20, right? At the low end. But the authors concluded that this decision aid is highly sensitive, which I agree with, and could reduce imaging. So you may not need to image as much. And then in your notebook, you should have that Ottawa subarachnoid hemorrhage rule there for you. Now, these studies are considered the classic studies that really informed and shifted practice. It was rigorously obtained. They did a really good job. It's a closed system in Ontario where I practice. In Canada, we have a closed system, right? Everybody has health insurance. It'd be really strange for someone to go, you know what, I'm going to go to the States and pay for this follow-up appointment, right? It's all there. So you can capture everybody, pretty much. Large sample size. And the first study showed that an LP is unnecessary after a negative CT head scan in under 6 hours. And the second one showed that testing isn't always even necessary. And if they have an answer of no to those 6 questions, then you can forego even getting a CT scan. But both studies are cohort studies, right? These are observational trials, right? Which is not observational trials, observational studies. So that's a lower form of evidence. And these clinical decision instruments and things like that, they need to be validated. And so this next abstract is the validation of this clinical decision. So the same group looked at implementing this clinical decision aid and to determine whether it actually had a measurable impact on practice. And what they're trying to find is, does it decrease the amount of scans? Because before that, it's like, you've got a headache, we're heading to the donut, right? You're my kind of patient, we're gonna do this, right? And is that really necessary? Do we need to be irradiating all of these people? And so CT rates were identical through LP, and admission rates were lower after the implementation. So before and after implementation, when they went to validate this, they found that the CT rates were identical. It didn't actually have much of an impact on CT rates, but LPs went down and admission rates were lower after implementation of this clinical decision instrument. Now, they found that the 6-hour rule in this was 96% sensitive, not 100%. And this is a theme that you'll see. When something comes out and it's like, wow, this is great, and they do it at the center that they've derived the rule, and then they go out to validate it, it's never quite as good, right? It's never quite as sensitive as it works. So why did the 6-hour rule and the clinical decision aid that they implemented in this study, why did it not reduce CT scans? Anybody got any thoughts? Why? You don't have any thoughts up front? You got nothing? Empty? The well is empty? Do you want me to throw you a bone? Do you want me to give you okay? So they did these studies at all the sites where they derived the tool. So you get these people, you train them, you tell them about this, and then later on down the road you try to validate it and say, did it change behavior? But these people were already aware of the rule, knew the rule, had used the rule before, and you go out and say, hey, does the rule work? And it's, oh, it didn't change much because that's what we're already doing. So whether it'll have an impact in other areas, so that's called external validity, would need to be demonstrated. So they already weren't doing a lot of excessive scans. So the next thing is, can the 6-hour rule be safely extended? Can you go beyond 6 hours? We've got updated technology. We're not using the same CT scanners that we were 10 years ago. And so will this new technology be able to pick up these small little bleeds, or if the bleeds happen and it's been reabsorbed, can we just use the CT scan to look at that? So this next abstract is a single hospital from New Zealand, so single center study using, quote, modern CT scanners. It was a retrospective observational study, so they're looking backwards at what they've been doing. And the primary outcome was the percentage of patients with a positive CT scan. They found almost 350 patients with a subarachnoid hemorrhage. 260 of them were aneurysmal. And they found that the CT was 97%, picked up 97%, so sensitive, true positive, aneurysmal, and 95% for all subarachnoid hemorrhages, aneurysmal and non-aneurysmal. And it didn't really matter on the time of onset. They found the sensitivity within 24 hours was 100%. Within 48 hours for aneurysmal ones, 99.6%. It seems pretty good. 48 hours for all subarachnoid hemorrhages, 99%. And those confidence intervals were fairly tight. So maybe with this new imaging technology, we won't have to put the limit at 6 hours and go, oh, when did the headache start? Oh, sorry, we're at 12:02. Sorry, that puts you at 6 hours and 2 minutes, right? Obviously, it's not that specific, but can we extend it? And so know what kind of scanners you're using. The next question is, so you have a negative CT, okay? You've scanned them, it's negative. How often, if you follow that up with an LP, will you pick up an aneurysmal subarachnoid hemorrhage? What's the yield? So there is such a thing as having a negative CT and a positive LP after. And the patient actually has a subarachnoid hemorrhage. It's not a false positive. It's rare, and there are downsides to doing LPs on all these negative CTs if you want to try to rule them out. So, I mean, the most obvious thing about doing an LP for someone who came in for a headache is post-LP headache. And so you know that clinical scenario, they come in, it's terrible headache, and who comes in with the best headache of their life, right? It's the worst headache of their life that day, right? And so they come in with the worst headache of their life, and then you go and you treat them appropriately, you start investigations and stuff like that, and by the time maybe you come around to do the LP, they're better. And you go, so we want to make sure it's not a subarachnoid hemorrhage, that's a bleed in your brain, and so we're going to take this needle. It's going to be an atraumatic, we'll be as gentle as possible and stuff like that. But I do need to tell you about the most common side effect, and that's going to be a headache once you have this done. Right? Like how well does that go over in your shared decision-making process? But there are other things. What else is there besides a post-LP headache? You know, they could get infected, you know, abscess formation, bleeds, things like that. So you can have other problems, but there's other things that you can pick up with an LP besides a subarachnoid hemorrhage that could be important clinically. But you think you'd have, oh, if you were worried about meningitis, well, you know, it was all that rash that they had, you know, that petechial rash, or that they've, you know, their temperature, oh God, I'm gonna have to do conversion, 38 point, okay, let's say 101 Fahrenheit, okay, that's a fever, right? Okay, so they have a fever. So you're going to be doing the LP for other reasons, and you can capture other stuff when you're doing that. So the next few studies tried to quantify the possibility of having a subarachnoid hemorrhage and the yield of an LP after a negative CT or a clean non-con CT head. So the first one, that's abstract number 5. This was a large observational study, again by Dr. Jeff Perry and his crew out of Ottawa. In 2015, they looked at the subset, so a subgroup analysis, of the patients who had had an LP to identify, you know, what's the best cutoff point with the number of red blood cells per high-powered field? What's the best cutoff for doing that as a marker of a subarachnoid hemorrhage? Now, interestingly, in the whole cohort, and remember, this is like, I think they did the study in 2011, right? Less than half the patients got an LP. Is that what it would have been like at your shop 10 years ago, 15 years ago, for people to rule out a subarachnoid hemorrhage? Only half getting an LP? I get the impression that LPs were more common down here. And of course, if they're not doing an LP, that's not the gold standard. If the gold standard is to do the LP to rule them out. So the other half, they just followed clinically. But in this case, 42% underwent an LP. That they were worried about a CT, worried about having a subarachnoid hemorrhage, a clean CT. 42% got the LP after the initial evaluation. 1/3 of those had at least one red blood cell per high-powered field or visible xanthochromium on the 4th tube. And a total of 15 aneurysmal subarachnoid hemorrhages were identified. Okay, 15. Okay, what did that actually work out to? That 15% had an LP finding a subarachnoid hemorrhage. Well, it gives you a number needed to tap an NNT of 250. So you'd have to tap 250 patients after a clean CT head to find one subarachnoid hemorrhage. I don't know, is that important? That's where the data needs to be interpreted. Do you want to do 250 taps to find that one patient? Is that medically, legally defensible in your practice environment? Certainly isn't my practice environment. What's that? You'd wait a little longer? Okay. Now in 2021, a neurosurgical group said, whoa, wait a minute. They conducted a systematic review of the literature looking at the diagnostic utility of LPs in CT negative patients and said, you know what? It's about 5%. Okay, 1 in 20, not 1 in 250. So we think the number is much higher based on compared to the Perry study. They had 3 studies when they looked, this neurosurgical group looked at 3 different studies, and the aneurysmal subarachnoid hemorrhage rate was about 0.9% in one group, so 1 in 100, and then it was 4.7 and 4.8. So it roughly worked out to about 1 in 20 when you pooled them all together. So the authors of this neurosurgical group said, you know what? LPs should still be continued because the yield is high enough as a proportion to warrant its continued use. That's their interpretation. Abstract number 7 comes at the question slightly different angle. This was a single center tertiary referral center over a dozen years. And the numbers weren't that surprising. They had about 1,600 patients, and 7% were diagnosed by LP. So 7%. That's a larger proportion than Perry, right? Perry had a much less, but it depends on what you consider. You know, Perry's study was, you know, like if you took the whole cohort, then it was 1 in 250 for number needed to tap. But in Perry's, you could also say it was 15 out of 145, which would be about 10%. So it depends on what denominator you use for that. And I always say the agenda is in the numerator and the devil's in the denominator. That's, you know, that's where it gets you. So anyways, these 2 independent research groups now confirmed a sizable proportion of subarachnoid hemorrhages can be identified by LP. However, 50% of the LP detected subarachnoid hemorrhages were aneurysmal. That means the other half were not aneurysmal. So were they actually traumatic taps? So those 2 abstracts made pretty aggressive assertions that you need to tap, right? One was a single center experience and suggests all patients should be considered for LPs. And if you want to say, well, yeah, I considered it, and I didn't do it, but you could consider it. But they say, you know, you should be considered doing this. The other says, even in patients presenting before 6 hours require a full workup, including an LP. So abstract number 8 is from a 3-hospital system, though, and comes to an opposite conclusion. It was a chart review, so this is observational data, over 5 years from Australian hospitals. And they found 1 patient. 1 patient had an aneurysmal subarachnoid hemorrhage that underwent the LP, that proved that they had a subarachnoid hemorrhage. But when they came back, they actually looked at the read again on the CT scan, and it was read by a trainee, and that's not, you know, we can all miss something, but they said, listen, I think that first CT was actually positive, not negative, so we didn't miss any, is what they were saying in that Australian study. So the bottom line is there is a small, but not 0 chance, or a percentage, of an aneurysmal subarachnoid hemorrhage will be missed on a non-contrast CT. And it's sort of like MIs. What's the level that you're willing to miss, or that the patients are willing to miss, or that your system is willing to miss? But it is a small number. It's not 0, but it's a small number. And so, you know, we advise that clinicians approach this saying it's unlikely, all right, that LPs, it's unlikely that the LP will find something that the CT missed, especially in that first 6 hours where we have the most robust data. The next question is there literature supporting a selective approach to LPs after a negative CT? So can you tease out and find those rare cases by having some kind of selective approach? Is there a way to do this? And so no studies or validated clinical decision aids exist to guide us on this, but abstract number 9 looks at the high quality studies, and then they come up with this test threshold. And it's a mathematical approach to doing diagnostics, right? And there's some math in there, and they promised me when I agreed to do this lecture that I'd have to do no math. And so I'm not going to go over the formula, okay? This is very theoretical, but it's that test threshold. Like, when does the pretest probability become so great that it's better to do the test than not do the test? And when is the pretest probability so low that that the results are probably going to be false positives, right? It's very, very much like doing your D-dimer and your PERC rule and stuff like that. It's very much based on sort of that. Does anybody know who did the pulmonary rule-out criteria rule? Does anybody know that one? PERC? Any PERC fans here? Do you know who did it?
He used to be from North Carolina.
Was he? It's Jeff Klein. Yeah, it's Jeff Klein. Yeah, he's the PE guru who came up with the PERC rule. So, we're familiar with this approach going, let's risk stratify these patients, right? Are they high risk, intermediate risk, low risk? That's what we do with Wells criteria, right? And if they're not high risk, if you're a dichotomizer, not high and high risk, you can use a D-dimer, or you can do high, intermediate, and low, and you can use a D-dimer, or you can apply the PERC rule after you've said they're low risk, and so I'm going to apply the PERC rule and not even do the test, because it doesn't help us in making our decision. So it does have some limitations to using this approach. Using this mathematical formula they plug into this, they have to look at what's the potential benefit. Okay, we're going to rule out a subarachnoid hemorrhage, and that's a devastating condition and stuff like that. Mortality is an issue, right? And the potential harms. But the harms are not all equal, right? And so choosing a single number, because the mathematical formula needs a number for harm. Well, do you consider harm death? Yeah, that's a harm from doing the LP. How about paralysis? How about headaches? How about pain? How about the time spent in the department? How about the time for the patient? Length of stay. What do you use for that number? So that's where you can play with it on that mathematical formula. But it's the concept that's important. And so they came up with this whole mathematical formula and said 1%. So if you think it's less than 1% likelihood, don't go down that path. If it's more than a 1% likelihood, then, and they've had a negative non-contrast CT, then go ahead and do the LP. So that 1% threshold is what they use. But the numbers are a little fuzzy, and so it leads to this whole idea of shared decision making. If the numbers are so fuzzy, why don't we share the decision and give patients autonomy and agency over their care? Abstract number 10 is a same sort of thing. It's a much more comprehensive effort to look at a test threshold, and this was done by my BFF. That's Dr. Chris Carpenter out of WashU. He's the smartest guy I know in this area, and he actually wrote the book. Like, he literally wrote the book on diagnostic testing. And so he published this and said, you know what? It's somewhere between 2 to 7% is the test threshold. So let's think 5%. Somewhere around 5%. If it's under 5%, you got a negative CT, and your pretest probability is under 5%, you don't need to do the LP. If you're going to, no, I think this is more, this is using your clinical judgment. It's like the person who comes in with chest pain and stuff like that, and you can use these clinical decision rules, but if I've got someone and my radar, my spidey senses are going off, I don't care what the score is. I'm worried about this patient, right? And there's something talking to me about that patient that I need to be more concerned about it, so it doesn't overrule your clinical judgment. But that test to threshold is an interesting concept. The next two papers came out of Annals, and it's two author groups. One is pro-LP, and one is con-LP. So the pro-authors, they say, listen, an LP is necessary in high-risk patients. I would agree. After 6 hours, and they cite the Perry paper saying after 6 hours, it didn't have 100% sensitivity in that Perry paper. It was under 6 hours. But they concede that for the average risk or the low-risk patient, an LP will probably do more harm than good. And then when you flip to that Annals article that had the con authors, they say, yeah, the LP is an imperfect test. It has low specificity. There's lots of false positives. Even in an academic environment, with things set up really well. But they concede that, LPs still may be necessary in some high-risk patients. So use your clinical judgment. So at the end of the day, I think both groups agree that patients with acute headache should not undergo an LP automatically and should not have an LP if you're concerned. If you're worried, do the test. And based on these publications, it can now be considered, quote, standard of care, most people are doing it, to do shared decision making about LPs with the patient themselves. Now, Abstract 13 looks into one possible future or way forward. You may be this is a tool that they're trying to come up with for shared decision making. It's not ready for prime time yet, but it's exciting that they're kind of coming up with these ways to communicate with patients on how to share that decision making. It's a Stanford-based group, and they've got this web-based risk calculator. You'll have the website there. You can take a look at it yourself, and it gives you a little dial that says, ooh, green to red and stuff like that. And they use a couple of examples, and one is, you've got a patient who comes in, instant peak, worst headache of their life, passed out, they can't move their neck, everything's going woot, 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 woot. I've got a high pretest probability, and even if it's within that 6 hours and the CT is negative, they say go ahead and get the LP, right, based on this shared decision-making model that they put forward. And then they put the opposite case. It's a young woman who has a history of migraines, who's been seen quite often, says it's the worst headache, it's a thunderclap headache, and there's some nausea with it and stuff like that. But they've had this headache multiple times before. Obviously, that's a low-risk probability. You might want to scan them, but if the scan is negative, you can be done, right? Because you've got a low pretest, and then the scan is, low likelihood. Low times low equals very low, but never zero, right? Not zero. So hopefully that eases some anxiety that we may feel with regards to admitting the LP. There is a recent publication that sheds some more light on this, though. The Perry paper was much better, but abstract number 14 is a chart review of 10 years of experience at a single center in New Zealand. And in abstract 14, they make a strong argument for the fact that there's been this improvement in the CT technology and that we can rely on it more than maybe the third generation stuff that they were using over a decade ago. And so it supports the notion that we can do this. The problem is it was a retrospective study, it's observational study, it's weak evidence, and so we need to be careful of not over-interpreting that. But the bottom line from this whole section is there's multiple author groups that now endorse a selective approach to doing LPs after a negative non-contrast CT, and that there are some clinical decision aids that are coming soon. And then the last thing is there anything else in the world of imaging that might help replace doing the LP? And probably some of you are doing this already, getting a CTA, right? And that's a possibility of doing that. The downsides, though, of doing a CTA is the false positives, right? 1 in 20, you'll find a little aneurysm that has nothing to do with their headache. If I scanned you guys, there's 50 of you here, right? A couple of you are going to have an aneurysm and nobody's having a headache, right? Well, you may be, but not caused by your aneurysm, right? So we have to be careful because that's going to subject those individuals to a lot of anxiety. Do you want to know that you've got a little thing waiting to go up at any time? Do you want every single time you ever have a headache going, oh, this is the one, it's going to pop, yeah, it's over, right? Or are you going to go ahead and get a surgical procedure? They're going to operate on your brain? It has some consequences, right? And so can we go with a CTA instead of doing an LP? And what's the risk benefit or potential harms and potential benefits by doing this? So the answers are still a little fuzzy, but there's 2 authors who wrote a commentary piece on it. One of them is, my mentor, Dr. Jerry Hoffman, a famous test minimizer, which I'm squarely in the camp of don't just do something, stand there. And not doing something is actually doing something. And so we have to take it from his perspective that he is a minimizer. But he has a solution to this idea of, well, what do you do if you've got a negative non-con CT head? Do you need to go ahead? And so his solution to the problem is for false positive incidental aneurysms is get an LP then. Just do the LP. That'll sort it out, right? Finally, the most important recent development is the ASAP policy has endorsed using a CTA as a potential next step to replace the LP. And this clinical policy was published in 2019, so you have some support there. So the bottom line is CTA is not really strongly supported by the literature, and it may have some potential ways to not doing the LP, but it can lead to unnecessary neurosurgical procedures, which can be a problem. It is endorsed by ACEP, likely to be safe, reasonable option, and clinicians, encourage them to sit down and, you guys are all sitting good, talk to your patients. Ask them what they care about, right? I know that's, I'm being a bit facetious, but like from evidence-based medicine standpoint, we go through all this literature, right? We go through this literature. Evidence-based medicine sits on 3 pillars. We've got the literature. We're critically appraising the literature. Then you apply your good clinical judgment. But the 3rd pillar is, what do you want? What do you value? What do you prefer? Have you ever had someone say, I don't want to stick around for the second trope? And is that a reasonable thing to do? Sure, they have agency. They can go off and drive without a seatbelt on, right? They can make decisions that we don't necessarily agree with. And so asking patients about this whole dilemma of getting an LP, getting a CTA, ruling out a subarachnoid hemorrhage is just a super rich area for having a shared decision-making process happen. So the key points and recommendations, CT within 6 hours after onset is highly sensitive. The first study said 100%. Of course, when they rolled it out further, it drifted down from 100%, except for that patient that you think is high risk, okay? So it also depends heavily on that the person reading the scan is really, really good at reading these scans. The subarachnoid hemorrhage rule can alleviate the need for doing subarachnoid hemorrhage testing in some patients. So if they answer no to those 6 questions, you don't even need to get a CT. That test threshold, somewhere between 1% to 5% of LPs will be positive for aneurysmal subarachnoid hemorrhages. About 5 to 15% are diagnosed by LP, but taking a selective approach to LPs is supported by experts in clinical policies, and many, and perhaps most patients with acute headaches are most likely to be harmed by an LP than helped, because we're not seeing, the prevalence isn't huge, right? And you've got to use clinical variables and modifiable risks and, to make these decisions when you're talking to patients. And clinical decision aids are coming. They're not there yet. And then you can always turn to a CTA as a potential way, as another strategy or as another pathway of not doing an LP after that CT scan.